of course, there are a number of different things, but and as you know, the presentation in this disease can also be quite variable. So unlike most blood cancers, it has a propensity to present as skin lesions in many patients. And like 20% of patients that we transplanted only had skin disease. So skin biopsy is important. And when you do the skin biopsy, it has to be read not just by a dermatologist, but sometimes even a hematopathologist can also take a look at it. So they would look at the morphology. Then there is a flow cytometry panel where they look at specific markers for BPDCN. After skin biopsy, we do bone marrow biopsy, just like any hematologic malignancies. And the bone marrow biopsy, again, morphology, flow cytometry. We also do cytogenetics and fish studies, because some of these patients can also have concurrent other blood cancers like CMML or MDS. So you would look for those abnormalities. There is no one specific chromosomal abnormalities that is unique to BPDCN, but we are learning more about that. And then there are molecular markers also. We do next generation sequencing on that bone marrow also. And there are certain genetic mutations that are being reported more and more. And one of them is this epigenetic marker, or one of the genes involved in methylation pathway, TET2, which in our patients, about 40% plus had TET2 mutation. So these are some of the things that we look at. We also do a spinal fluid exam, because 20 to 30% of these patients, even without symptoms, may have cerebrospinal fluid involvement. So we look at the CSF also. So skin biopsy, bone marrow biopsy with morphology, flow cytometry, cytogenetics, molecular panel, and spinal fluid examination in a nutshell.